I want to talk tonight about the labral reconstruction and how I got to this point and why it really is the procedure of choice for the torn labrum. What is my motivation? It's actually, it's patients like this. So you look at this and you think, well, God, that's got to be an old patient. Well, this is actually a 15-year-old. I think that the problem and the thing that makes me sad and professionally is getting challenging for me is that more and more people are doing hip arthroscopy. And that's a natural extension, and that is what it is. But the problem is, I think that the thing that comes with that is I think that there's also a feeling that, oh, it's just a hip scope. You get it done, you'll be back on the ski slope. And some people are even marketing that they'll get you back playing sports in 2 or 3 months. And this procedure, as you saw, is a huge procedure on the inside, hidden by the fact it's arthroscopic. And so when less experienced surgeons get involved with this is a labrum that shouldn't be in a 15-year-old, it's shredded. And so this is what they do, because they don't, it's hard, right? And so this is a pretty ugly labral repair. Now the tissue that they started with was horrible, but then unfortunately, it didn't work, so they went back to the OR again. And they just debrided it. This just breaks my heart, especially having kids. This is now a 17-year-old who's not playing soccer, it's not going to play collegiate soccer. Thankfully, they're going to come to us and we'll give a go at a reconstruction. But unfortunately, these are my revisions. I'm behind the 8 ball here. And we'll give her everything we have. But I think it's just important to note where hip arthroscopy is going and to value the procedure and to recognize that it just needs to be done by those who do it only and exclusively. Because it's not a knee scope. It's not a shoulder scope. It's a very different procedure. So when we back up, why do we operate on the hip? Because of dysplasia? Because of cam type impingement? Because of labral tears? No. We operate because of pain, okay? And so when we back up and look at the joint, the labrum is the primary source of pain in the joint. Now there are other things that hurt, but this is the global thing that causes the most pain. Again, the hip is simple, just a ball and socket joint. The two need to fit well together. Now I've looked at thousands of x-rays in the 11 years that I've been in practice. I've not seen the same hip. They're all subtly different, okay? But in general, you just need to have just the right fit for that individual patient. And it's all about balance. If it's not right, then that's when you get labral tears, and that's when problems occur. How did I get to this point? I started at Western in 2008 after training in Vail. Almost immediately I focused on the hip. And it wasn't really by choice. It just sort of happened because that was an opening and that was an area. And it was like a well-cultivated weed because it just kept growing and growing. And it really became a lot of fun because it was this world where you could learn a lot and get better at it and deal with all the problems as they were growing through this. And I was actually one of the first on the front range to repair the labrum, which is kind of funny because now people think I just reconstruct the labrum, which is true, but I did a ton of repairs. In fact, I did over 1,000. The best decision I made early, and it was one of the things that stuck with me from fellowship, one of the guys who came to visit us said, if you're going to do a procedure in high volume, you owe it to yourself and to your community to start a database. Okay? And I think that really stuck with me because I started in 2009. And this was early in my practice, and it was a decision I made financially to do. And it was nice because it always allowed me to continuously, objectively assess my work and decisions made in the operating room and see, what trends were real and to figure out what direction to go with my practice. At this point, we have nearly 4,000 hip arthroscopies in the database, which is a tremendous amount of information. My current practice, I've been in practice for 11 years. I work for about 70 to 80 hours per week. That's hard to fathom. I don't sleep that much. I don't need it. But I really am balanced by my family and really by the demand for what we do, especially those revisions. And it's really motivating to get these people fixed. I do about 440 hip arthroscopies. Every single one is a labral reconstruction. I don't do anything but. I don't do debridements. I don't do repairs. Everything's a reconstruction. I also do about 60 combined hip arthroscopies with Gons osteotomies with Dr. Presley Swan. That probably is going to continue to escalate. It seems like we're more on pace now for about 80 to 100 this year. And that's a great procedure because it recognizes humility. I can't do a Gons. There's no way I can do it. I'm not trained to do it. Presley can do a very nice Gons osteotomy. I could do the scope part. It's very hard to scope a dysplastic hip. So I do that part, he does the Gons. But then the cool thing is because we do it in the same hospital and they're separated by a week or so, then I help with the correction. And so the two of us are in the room and we decide on the correction, work on the correction together, hold it and maintain it while it's done. That's a unique offering, and I think that's really getting a lot of these hips really nice. And I do about 60 total hips per year. And really how all this is possible is because of everybody on this slide. My family, first and foremost, my strength comes through my wife and my family. The OR, you saw all of them up there. Our physical therapists here in the hospital, all of you physical therapists who take great care of our patients but also help people get to us on the first line. Our nurses on 5 North and 4 North, my clinic, and I think you guys saw a lot of our staff here tonight, Danielle, Donna, and Teresa, and then Sean wasn't able to be here, but he's my PA. And he's the one who helps me a lot during the week because I'm in the OR 4 days a week. And so he is in the clinic on Monday, Tuesday, Thursday, Friday, because the big thing for me is even though we run this high volume, it is not a machine. We take care of everybody individually. I might be late in clinic because I can't get pulled in too many directions, but the bottom line is that everyone gets our time and everyone gets everything from us to make sure it's done perfectly. And then Carrie and Molly are the ones who take wonderful care of our patients here in the hospital with me. So labral repair, from the start, this is what I did. I repaired everything. I did 1,000 repairs. And what started happening is some of them started to fail when I first started. So then I did what was the standard, which was to go in and remove the adhesions and re-repair the labrum. The problem was the failure rate was 50%. And that was heartbreaking for me because that was it within the first few years of practice. And I still know all those patients' names. And a lot of them I ended up doing a labral reconstruction on. And that's what I started to do in 2010 for the revisions. But at the same time, I was still repairing the labrum. So I had this situation in the database, which was really kind of helpful because I had a bunch of repairs. I had degenerative repairs, I had diabetic repairs, and I had reconstructions for revisions. And we could look at them objectively together, and the reconstructions just kept doing better. And that didn't make sense because the reconstructions were done in worse cases. They were done in revisions. But objectively they were. And so I started applying the labral reconstructions to complex primary cases. Ehlers-Danlos syndrome, that's a very challenging hip. That works a lot better with a labral reconstruction. Inflammatory arthritis, same thing. One of the surgeons in Chicago, Pat Birmingham, who I taught several years ago, told me when we first met that he would never operate on an inflammatory arthritis patient, even though they were well controlled with a labral tear because they just didn't do well. And I said, well, try a reconstruction. It's nice, fully converted. It's just a completely different procedure in that regard. Workers' compensation, the same, age over 45 and diabetes. And the reconstructions just kept getting better and better. And the reason was it's an ideal solution because you go back to that first slide, you remove the painful labral tissue. You take it out of the joint. And that's why the patient came to see you in the first place. But the big thing is that we all know that the labrum is important mechanically. So you put it back in, but the graft material should always be aneural, and it shouldn't be able to feel or perceive pain anywhere near to the same degree. And we have with this procedure the ability, as you saw, to reproduce normal anatomy. Our grafts are huge. They go all the way around the back now. They're nearly circumferential. And for those that question graft incorporation, because I always have this conversation with surgeons, because it's an intuitive thing. It's a new thing. You should question it a little bit. But nobody questions an ACL graft anymore because it's been established forever, and we watch people come back from football injuries and play football again. And you really should question the ACL because it's constantly under tension, and there's at least an inch gap between the tibia and the femur that's bathed in synovial fluid. And so that should be hard to incorporate, but it does. The reconstruction. You shouldn't really question because, number one, the clinical data, but the other thing is that it's constantly under compression. This is the best bone and blood in the body because this is where you get your bone marrow harvest and everything else. And then the entirety of the graft, instead of having a gap, is fixed down to bleeding bone, as you saw. Why is the labrum important? It enhances acetabular volume by 20%. 20%. So for all these borderline dysplastics, Ehlers-Danlos patients, loosey-goosey young girls, you need to have a labrum. Okay, you can't get a debridement. If you get a repair and you look at the pictures, because you guys are objectively looking at the work that's coming into your clinic, and somebody repairs a 1 to 2 millimeter little threaded labrum, they don't really have a labrum. They're labrum deficient. That labrum's not working for them. It needs to form a seal with the femoral head. That's how you keep joint fluid inside of the joint. Joint fluid's how the cartilage gets nutrition because all nutrition comes through diffusion. So it's just like looking at the cartilage as a sponge. So if you can't seal off that joint fluid, that fluid gets out, the cartilage can't get its nutrition. And then lastly, it protects the cartilage from shear force. So if you think about it, cartilage is like a box spring mattress. Okay, so it's designed to take compressive loads. It's not designed to take those shear loads. Okay, and that's why people who tear their ACL, that's why they injure the cartilage on the tibia and the femur, because that's that big shear force or blow to the cartilage. The hip's the same. Okay, it's a circle. And so it's a constant shearing rotational force with the hip rotating in and out, okay? So the problem is that cartilage on the edge. If you don't have a labrum, you're going to continue to see a shear force. If you have a labrum, it blocks the shear force, so the cartilage on the edge can just see compression. Does that make sense? So that's why you've got to have your labrum, and that's why we love it. So why are the results with labral repairs inconsistent? It's because the blood supply is compromised with the repair technique. It's also because the labrum is chronically injured. These aren't acute injuries. They never are. Even if the patient said, look, it just started hurting last month, the impingement's been there since they've been 13. The last part is that even though you take down the circulation, you still keep the innervation to the labral tissue. So it's still a sensate piece of tissue, so it still could be an irritant later. So when you look at the current repair technique, this is a great slide because when you look at it, you can see this is the ball, the pink is the cartilage, this is the cup, this is the cartilage blending into the labrum. And so when you take a look at it, the cartilage side of the labrum is completely devoid of blood supply. It all comes from the peripheral side. And so when you do a labral repair, your first technique is you have to expose the bone so you can get an anchor in and so you can excite the bone to heal. But the problem is, to do that, you transect the blood vessels and the vascular supply to the labrum. And in every orthopedic textbook, for every orthopedic problem that I've ever studied, never is the first step for repairing a fracture or anything else taking down the blood supply to get exposure. It's preserving the blood supply. And you can't get to the back of the labrum without cutting it out. If you really think hard about this, and I will wager all the money in Cameron's wallet, if we don't repair any ligament or meniscal structure in the body that's chronically torn. If you can come up with something other than maybe a Bankart repair in the shoulder, which is really a capsular shift, you can let me know. But there's nothing now that's repaired. Everything is reconstructed. ACLs, everything else. Even ankle ligaments. And so when you think about it, every labral tear represents a chronic injury. And our natural orthopedic evolution in other joints is we don't know what the problem is, then we figure out what the problem is. And we say, you know what, that looks torn, we're going to just remove it. And we say, you know what, I can't remove this, you're too young, or there's a reason for it, we're going to try and repair it. Then the repairs don't work quite as well, then we go to the reconstruction. And then the reconstruction eventually evolves to something that's increasingly more anatomic. The labrum should be no different. Total hip replacements, arguably the best procedure that we have in orthopedics. Does have some bad complications, but thankfully they're very rare. But with regard to taking away pain, this is the holy grail. And it doesn't matter what hip you give me. You can give me the top or the bottom, all very different. They're all the same afterwards. And it's because it's a standardized procedure. The results of hip arthroscopy, when you think about it, all of these hips, this was a sampling from a month. Every single one of these labrums, small and shredded, previously thermally treated, red and inflamed, just about right in size, big and bloated, okay? Every single one of those results is not going to be because somebody uses a special suture anchor, a different repair technique, or has 8 years of experience versus 1 year of experience. It's all going to come back to the quality of the tissue that you start with. And the nice thing is that the reconstruction allows you to make every single hip exactly the same. It allows you to standardize the procedure, which is how we objectively make all procedures in orthopedics successful across the board. The elements of the arthroscopy, you saw most of them tonight. The first is to reshape the ball and the cup to treat the cam and the pincer. Okay, got to get the ball and cup to fit well together. Labral reconstruction for me, then the soft tissue additions. I think psoas release has fallen out of favor. I think you guys had a lot to do with that. That was a procedure that we thought was a really good procedure before, and I'll go through it. But probably now, the pendulum has swung so far, I don't think you'll see it happening much anymore. Capsule preservation, imbrication, I think tightening up the capsule in EDS patients I think is helpful. Greater trochanteric work, I think helpful in the right patient. And then Gons osteotomies for dysplasia. The other one that jumps around quite a bit, just given our proximity to Boulder, is femoral version and whether or not this should be treated. When you look at femoral version, that describes the angle, okay, from the shaft of the femur and the neck. Okay, so the neck comes forward usually at 12 to 15 degrees. Sometimes it can be backwards, sometimes it can be forward anymore. The huge problem I have with this is that normal is 12 to 15 degrees. Now, again, let's go back. I've looked at 10,000 x-rays at least, probably more. I've not seen the same hip yet. Okay? There's no way that that range is that small. The way that got developed was from basically osteology studies where they looked at a bag of bones from, I think it was Cleveland Clinic and a couple other ones where they've got, skeletons from 1800 or something. And they basically looked at them and they measured all the femoral version and they came up with this as the range. And so the problem is in a very gray type of surgery where you're trying to look at a hip that is objectively very different across the board, we now have this very narrow margin for what's normal. The theory is that if you have increased femoral anaversion and you combine that with some form of dysplasia or hyperlaxity, your ball now is less covered than it should be, so it can exacerbate your instability. The one thing that is definitely true is that if you have increased femoral version, that's a no-no for a psoas release, absolutely, because then that loses your dynamic constraint and pull over the front of the joint. But the femoral osteotomy, you're starting to see it more liberally applied across the board, okay, as a reason for people failing a previous hip scope. The hard part with it is that I think it really should be rarely indicated, and I think very few are considering the patellofemoral implications and also the gait implications and the fact that it just completely moves your foot to a different position and you have to learn how to do it again. And unless both sides are being done, you're now asymmetric. And so it really is a bigger procedure than just changing it at the hip level. There are a lot of downstream ramifications. The two that we did had horrible patellofemoral dislocations, and so it was beneficial to combine it with that procedure. But the recoveries are hard. The reshaping, again, meticulous. You see my nature, but you can take awful shapes, okay, and you can make them round. It just takes time. You can take awful pincers, and you can make the cup normal, but you have to spend the time to do it. And then the trochanteric work, I think it is reasonable to think about, because again, we all know that the trochanteric pain syndrome is probably not just a bursitis. It's a dynamic problem, and I think the key for this is just becoming gluteus dominant again and normalizing gait so there's no pelvic tilt. Okay, pelvic tilt is sort of the enemy of all physical therapists and all orthopedic surgeons. The psoas release, it really kind of, and I think this is where you're seeing femoral version creep into our world a little bit. A lot of times you're seeing the pediatric orthopedic surgeons evolve into hip preservation centers and then application of hip preservation, pediatric orthopedic principles being applied now to adult surgeries. That's where femoral version came in, okay? That's how it came into our world. This is the other one that is sort of an extension of that. It's a myotendinous release, okay? So it wasn't very few were released from the bone. It was where the tendon joined the muscle and the thought that you were doing a slide. So it was kind of like a procedure called a tendo-Achilles lengthening that you did for kids with cerebral palsy so that they could get their feet flat, okay? It was applied to the hip and it worked well in a lot of patients. I mean, I did a couple hundred. But you can't control how much it slides, and you can't control what it does to your psoas afterwards. And this was really the patient, and she's a physical therapist, that really changed me forever. I had done a psoas release on her, and this is her normal psoas muscle belly on the side I didn't do anything with, and this was the psoas muscle belly on the side I had worked on. Now, was that me? Was that her concomitant lumbar pathology? I think I'm going to take ownership for that because I think it probably has something to do with the way that the psoas pulled back and then has had atrophy since. So to me, I will never do it again. I look at the psoas as your problem. And so I fix the joint, you fix the tilt, so it should relax a little bit. I tell the patients that they might still pop afterwards, but they won't be popping over a painful labrum, so it shouldn't hurt. Some people are just built a little bit tight, but typically, in all seriousness, I think that that's the form of rehabilitation, and then dealing with what you have afterwards. How did I objectively validate where we are with this? Well, I'm actually very academic, despite the fact I'm in private practice. I've written several peer-reviewed papers, which I'll go through, and I lecture all over about this. I also educate a ton of orthopedic surgeons. I do 2 courses per year here in Denver, and I have about 30 to 40 surgeons per year that visit, and then that live broadcast that you maybe didn't quite see fully with the 4 different screens, but I do that now all over the world to teach. A lot of this has been to get back to that picture, to be home with my family. I hate leaving my family. I will never do it again. And Porter has been wonderful enough to give me the support to be able to broadcast and then host these courses here. And thankfully, we're under enough demand that people will travel for me instead of me traveling for them. So I'm very grateful for that. But I want to teach because even if somebody, I can't get them to the level of doing a labral reconstruction, but if I can get their repairs better and if I can get their brain better, I think that then I'm helping more people than just the ones we can operate on, so that's important to me. This was our first paper where we described the front-to-back technique in validated allograft. We published it in January of 2016. We had 114 hips, excuse me, which is a huge number. The age range was 16 to 57. Average age was 39. So that already puts a little asterisk on the paper with regard to the challenge of the patients. That's a hard age. 88 were primary, 36 were revisions. The cool thing is that the Harris hip score improvement was 34. Is anyone familiar with that? Okay. So, you know, if you look at those scores, if you just have mild pain that doesn't affect you at all, you go from 100 to an 87. Okay, so it's pretty easy to get pretty low down on those scores. And so our average at final was 87, which I was proud of, and the 34-point jump was good because when you look at the hip arthroscopy literature, a paper can get published with an improvement of 16 to 24. So we were a good third better than all the coexisting literature on hip arthroscopy. The value, it showed the potential of reconstruction. It validated, it's the largest cohort to date on labral reconstructions and will be for a while. It validates allograft in its first description of that front-to-back technique. The reason why we did that again is that the short segmental grafts, or if you do fixing in the front and then fix it in the back and then in between, it's hard to get the graft length right. So this way, as you saw, we could cut it inside so that we would have the perfect length every time. For revisions, this was a big paper as well because there wasn't really the standard for revisions outside of re-repairing the labrum. And so as I had such a high failure rate, we looked at 104 patients, 14 re-repairs, 90 reconstructions. There was a 50% failure rate with re-repair. So I think that's a garbage procedure. I don't think it ever should be done. I think it's an absolute waste of time, and it hurts patients because it creates more scarring, more problems, and then, you know, another year of rehabilitation and going to see other specialists to see what the residual problem is. Reconstruction's failure rate was 12%, not perfect, okay? I think some of these situations are just tough, but the reality is that that's a big difference between the two, and we had 92% follow-up despite that large cohort. So it was a 4.1 times higher failure rate with reconstruction. I also studied in this the segmental versus the non-segmental grafts, and we had better results with the longer grafts. So that actually has been studied as a sidebar in this paper. And then despite the fact that this was a revision paper, again, 32-point jump, okay, in our Harris hip score. So objectively, that's an excellent result. And so the value of this, it's a no-brainer. If you fail a hip scope, second procedure is a labral reconstruction with a considerably lower failure rate. And it has set, over the years, the standard for revisions across the board. This is the one that really generated a ton of controversy in my insular world of hip arthroscopists around the world because, as I said when we were doing our case, it's really clean because it's really simple. It's not a multivariate analysis of 20 people who are age matched and weight matched, and no, it's just people. And I operated on both of their hips, and I was the one that did the surgery. Nobody else did it. I did a repair on one side, a reconstruction on the other. That is the cleanest comparison, and I would argue that that's a better study than a prospective randomized study because two 22-year-old females are not the same. Okay, and so we had 29 patients. We got 100% follow-up. We didn't lose a single patient. We had minimum of 2-year follow-up. It was published about a year ago. None of the reconstructions failed. 31% of the repairs failed, and so that's a huge difference. The clinical outcomes were similar in both groups that did not fail. So in other words, Harris hip score improvement, level of satisfaction, they were all very similar. So I think both forms of treatment can do well, but the reconstruction for me is far more predictable. And I also kind of concluded from this that it's the rule of the thirds with labral repairs from that. I think a third can have an excellent result. I think a third do better, but they have some limitations. So they're sort of the meh result, Like I can't run, but I can sit better. And I'm not grouchy all the time. I'm mostly happy. And I'm overall pretty glad I did it. And then there's a third that do poorly, and they potentially would have another surgery if it were offered to them. And I just took care of a radiology tech who lives up in Salida, and she said, she's talking to a lot of patients who had a labral repair elsewhere, and they were older, and they all said to her, it didn't really help, I wouldn't do it again. And I think, unfortunately, there are a lot of people in that world that just don't know there's another option. And I think these patients had such a low threshold to have another surgery, again, because it wasn't this abstract concept of doing a reconstruction with the academic merit and everything else, it was just like, okay, I don't like this hip, just do what you did on this side and give it to me on this side. And so that was their movement towards it. A lot of surgeons have been threatened by this paper because they say that their labral repair failure rate is not this high. And so it's really been an interesting year from the backlash from all of it. But I think it's really shown objectively that this is just a better procedure. So I think with all of these studies, when you put them together, the front to back technique is a good technique. You can use allograft. You don't have to use autograft. Autograft, again, for the hip is a killer for the hip. You're going to take IT band. You just can't touch the IT band. You've got to leave it alone. The reconstruction is absolutely the standard for revisions. And in my practice, in my hands, labral reconstruction is superior to labral repairs. And so, when you take a look at it, you see labrums like this more often than you think. And unfortunately, the only reason why you repair them is because you just don't have anything else. You have no other feathers in your cap. And unfortunately, you see this more than you think. Again, this is my standard, okay? Nice labral reconstructions. The limitations to it becoming widespread is very simple. It's a very, very, very hard procedure. There are a lot of steps. There are a lot of parts that can go wrong. It needs somebody who's an expert and devoted to this to be able to do it. We're now at about 3,000. I think we hit 3,000 this fall. It takes about 3 to 5 hours, and sometimes even 6. That doesn't fit a lot of people, right? Because this is the world where we want to do a large volume of surgeries in an efficient period of time. This doesn't fit into a lot of people's practice. It's definitely not ideal for a surgery center. Okay, surgery centers are starting to look at how much is utilized, right? In this case, I used 2 burrs. I used a thermal device. I used 11 anchors, and I used a graft. Now that's the right thing for the patient. I don't want to be compromised at all by a surgery center, and I've had wonderful support from Porter to do the right thing for patients, and that's how we're able to do it. I think the other thing and the problem with it is that if it's performed poorly, it's really hard to fix. A lot of times what we're seeing is that when people are taking this on without much experience, the classic mistake is they think they have to burr the cup very aggressively, and they take so much cup they make the patient dysplastic. And so a lot of times they're ruining the joint. And then when you're working in those tight spaces, you can really drive the cup or drive the scope across the head, and you can really cause a lot of damage to the head, as you saw in that first case I showed. So I think it's one of those things that probably should be used by a few people and not everybody, unless you're going to devote yourself to this. The rehabilitation, really for reconstruction repairs for me, it's interesting because when I started, it was 30% weight bearing for 2 weeks. And then I had a couple people who were too inflamed, so I made it 3 weeks. And then I wasn't quite sure, so then I made it 4 weeks. And I've never gone back. I've never made it lighter. I don't bang on my chest and say, I'm going to get you back to skiing in 2 months. I think those are wrong things to say. I think the key is, in the beginning, what we want to do is we want to cool off the inflammation. Because if you guys can cool off the inflammation and get back range of motion, then you're going to be able to build up the muscles. You can never strengthen an inflamed joint. It just won't happen, and it's impossible. Microfracture is when we do 20% for 6 weeks. Okay, so just a little bit less and a little bit longer on the bending machine. You never really want to be non-weight bearing, because the tendency with that is you're just going to hike your knee and you're going to put a constant ton of contraction on your hip flexor, and you're just going to be behind the 8 ball from then moving forward. So never non-weight bearing. External rotation to neutral for 2 weeks. Again, that's why we're going to protect the capsule so that it heals in the front. I made this slide. I thought it was really nice. I'm sure all of you guys think it's pretty basic, but the bottom line is that the hip hates tilt, right? So if we've operated on this hip and they start to limp, okay, this pelvis drops. And if the glutes are paralyzed from surgery or out or just weak, or it's the end of the day and they've just fizzled away, these two start pulling over, okay? Because the body's very simple. If I stand level, my body weight falls between my 2 feet. And that keeps my head designed level so that I can look at you and focus, and I don't get dizzy and I don't throw up, okay? And so when I stand up on one leg, I basically shift my body weight over 1 foot, okay? But we don't walk back and forth like that, okay? When we walk, we do this weird thing where we plant our right leg and we basically transfer through with all of our body weight to the inside of our planted leg. The only way our pelvis stays level is because our glutes hold our pelvis level and prevent us from dipping. In general, phase 1, reduce inflammation, recruit the glutes, and just try and get a normal basic gait. Remembering, if they're limping at all, use a crutch on the other hand at least to minimize that potential for that pelvis to tilt. Phase 2, increasing your gluteus endurance and balance your musculature. Danielle and I just looked at a gal about 3 months ago. She was 2 months out. She was a long jumper up in Gunnison. She was so proud of herself because she was doing single leg squats. And I said, well, let me see them, because it was, I think, just short of 2 months, I think. And you watched her do it, and every time she did it, the form was awful. And so, yes, she was doing well. Yes, we were proud of her because she was pushing herself so hard and doing everything right. But she actually needed to go back to the more basics because she wasn't ready for the more advanced. 3 is when you get higher level function. 4 is when you get to the return to sport. The art of this is moving between the phases. I think in general, this is about a 6 month to 2 year process. I think that's fair. I think that's safe. I think that's conservative, and that's going to get the vast majority of your patients to the finish line. I think when you deviate from this, or at least when I've deviated from this, because a young girl has a college tryout for soccer and she thinks she's ready, and I say I've always been burned. And so I just say 6 months, and I just don't deviate. Now, they may not listen. That's their choice. But I think for us, it's probably safer to keep them safe for a while because there's subtle things that happen. And we just had a fisherman from Alaska, and he came down, and at 2 months, he felt great. His pain was gone. He said, Brian, I'm good. He said, I have an opportunity to be a captain. I should take this. I said, I just don't think you're ready. The thing passed. He just wasn't able to do it. Came back at 4 months. He said, I'm definitely ready this time. I said, we'll have to see. I'm nervous about the deck and your balance. I don't think it's safe right now. At 6 months, he came in, and he said, I finally get it. I didn't get it before, but now I get it. Every time I look back at those other time points, I realize I really wasn't ready. Now I really, truly feel ready, and we've not heard from him in years. So I think they're not always going to believe you because they're out of pain, and they feel great, and they're functioning great. But there's subtle things that are happening in their body that just need time. A lot of the difference between the 6 month and 2 years, I think age. I think how much deconditioning they have. I think comorbidities like diabetes, smoking, these things make a difference. Workers' compensation, very challenging. And so I think this is where you guys do a wonderful job of mentally enlisting them in your process. And I think that really helps. The other part that I think is hard is when your basic exercises are painful. And when the return to gate's a little bit slow. And that's where I just have a low threshold to go in the pool. The cold water helps. People see progress. They see improvement. And it can just get them mentally over a hump. And it can also help them, instead of working on their gait and dry, full weight bearing, it's kind of like the Ultra G a little bit. And it just helps them get in a good position to move forward with it. Pelvic floor is always something to think of. If the pain is just really deep and just feels like it's up inside, and we looked at 5 screening questions that help with this. Do you have pain with intercourse? Do you have difficulty with bowel movements? Have you had children? Do you have difficulty urinating? Oh shoot, and I can't remember the 5th one. Do you remember the 5th one? We got them from N2. But it's good just to kind of go through a basic screen and see if that's part of it. Because I think you can kind of spin your head around in circles chasing something that probably isn't quite in your direct world. And for a lot of women, unfortunately, it seems like a lot of women will kind of put themselves off last. And I just had a conversation with a patient a couple weeks ago, and she said, it's now my turn. I've been taking care of my husband, my kids, and I can't walk the dog anymore. But this fall, I got to give myself the time. And by the time they give themselves the time to do it, so many things have happened to their body that it makes it hard for them to come around. And so these are the things that when you get to know patients, it helps to figure it out. Always individualize the therapy. Every patient is different. I really think that the art of all this is knowing when to progress between the phases. Okay, that's the big thing. If you're ever in doubt, spend an extra week or 2, or add a couple exercises and back up for a week, and just see. Because the hard part is that they're not going to show you in their clinic that they're having trouble, but they'll know in a couple days or a couple days of doing that they're getting in trouble. Always avoid the catch-up PT. There's so many patients that are young and they'll do their surgery and they'll start doing the rehab and they do great. And so then they go out and have these big weekends, and then you spend like 3 days dry needling them, and then they feel great by the end of the week, and then they go out and and it's just like, we got to just stop circling the drain. We got to start making progress, and they have to understand that. Speed kills in general, just breach patience. Big things for me with all of this is obviously we have opened up Western Orthopaedics PT. I don't think that we're alone. I think every orthopedic group has done it. It's an obvious collaboration. My intent is that, Danielle and her team, they are fabulous. Number one, they can't take care of everybody. Number two, it's not my intent to bring everybody downtown. We're not geographically convenient for that many people. Number three, I respect your referrals. If you send patients to me, my intent is to get them back to you. If that hasn't been the case or is not the case, we want to know about it, because everybody in my clinic, from Teresa to Danielle to Donna to Sean, knows that you have figured out the problem, you have the relationship, you should take them through the finish line here. If, as a physical therapist, you're battling hip flexor tendonitis, adductor issues, something that doesn't make sense to you, I don't think I'm going to figure it out, but I'd like to see the patient and make sure that I think the joint's okay. But that's where I would like Western Orthopaedics PT to be a resource for you, so that you guys can collaborate together, because there's some patients that I need some of my friends, Andy Wolf in DC. I need them to take a look at a case and say, Andy, I don't know what I'm doing here. I don't know what's going on. This doesn't seem right. That's what we're meant to be here for, okay? And I want you to know that, and I mean that. So I think the bottom line is you guys have been wonderful partners through this journey that I've made. I feel like I've learned a lot about the hip over the years. I feel like we've gotten to a good place. I haven't figured everything out. I'm curious to see where this talk will be in 10 years, but I appreciate this evening and you guys coming in here and making the commitment to the hip with me, and I thank you guys very much.